Good afternoon. We have with us Dr. Arghya Majumdar, the Director and Head of Nephrology and Critical Care, AMRI Manipal Hospital. We welcome you to the Natco Pharma Specialty Studio, and we would love to hear your insight in the space of critical care management, especially those associated with antibacterial resistance. Doctor, what are the changes you have foreseen in critical care management?
Well, recently in the infection spectrum, we have seen more and more, gram-negative organisms which are resistant to the standard antibiotics and carbapenem is producing, and often MBLs, and even gram-positive resistance, which was not a problem in India, even that is becoming worse. We are seeing more MRSs and VREs, with the use of vancomycin. So antibiotic resistance is a big problem because most of the patients, either if they're admitted with septic shock or if they're admitted with some other condition like pancreatitis or even COVID times, we saw this, and they soon develop uh, hospital-acquired infection with a very multi-resistant organism. So that is a major problem in ITU.
Doctor, from your years of experience, what is it that you would like to advise the young ICU doctors and so that they are able to enhance patient care?
Yeah, I think in this regard, it's very important to have a antibiotic stewardship program, and they must learn, what to use as the first antibiotic and then send off proper cultures. And now we have, biofire. And so really counsel the patients and relatives and to go for, biofire examination, which can give us an idea about the antibiotic resistance genes, right within 4 or 5 hours of admission. So we know if it's OXA or AMC or MBL, and so we can target the antibiotic immediately. So I think the whole management spectrum has changed because previously we had to wait, 48 hours till the culture will come back and then change from your prophylactic empirical antibiotic to the definitive antibiotic. So I think biofire has made a big difference, and we should utilize this, and it will drastically change ITU management.
You spoke sometime earlier about carbapenem. So, what is the prevalence in your practice, doctor, for the producing bacteria that takes place?
It is increasing. It is quite high. We don't have exact figures, but I think in some, particularly in UTIs and with Klebsiella, we see a higher carbapenem producing. So almost 30 to 40% compared to E. coli is still better, but Klebsiella is really worse and asymptomatic.
What are the treatment options you would like to bring about when you find such cases?
Well, at the moment, the available antibiotics we have, ceftazidime, avibactam, and that is a big boon. And we use this drug as soon as we know that this carbapenem is producing. And if the patient is also a MBL or producing, then along with it, we add aztreonam in a Y channel and give the infusion together. And so that is the current our savior kind of. The use of polymyxins and colistin has gone down with the arrival of this antibiotic. Yeah.
Right, Dr. Aragya, we thank you for your time in the studio and for sharing these valuable insights. We wish you all the best.